Thank you very much, Tarun, and I again welcome everyone who's joined and who are going to join, because I understand that today a lot of activities going on throughout oncology, specialists. So basically today we'll be discussing about the lung cancer. We know that lung cancer is one of the commonest, in fact, in male after the oral and head and neck cancer, it is the commonest cancer. And the problem in our country is that what we get, the what we call resectable is are very less. The stage 1 and 2, they're roughly about 3 to 4% only, and even lesser in our country, where all different studies have shown. Majority are in stage 4, that is more than 60% what we get in stage 4. As we know that small cell lung cancer constitute 15%, and rest are the non-small cell, and then we have now the majority is going towards the adenocarcinoma rather than the squamous cell carcinoma, which is becoming lesser. Why we do have this stage 4 more rather than early lung cancer? Basically, it is a misdiagnosed, which we have. We have a physician all over country who are very good physician otherwise, but they also are good, they treat a lot of pulmonary tuberculosis. So in this, when they are treating pulmonary tuberculosis, most of the patients who are lung cancer, because lung cancer mimic pulmonary tuberculosis. In our country, doing AFB testing or doing biopsy is less prevalent as compared to any other. Even in tertiary care center, a patient comes, the effort is not made to do the biopsy to come to the conclusion of the diagnosis, but rather patient is put on ATT, and then after 6 months or 3 months, when there is no response and there is a progression of shadows on X-rays, when further evaluation is concerned. So a lot of precious time is lost in this, and that is why we have many stage 4 disease. And even I still request if physicians are around that they should not start ATT unless they have a confirmed diagnosis. I understand that it is difficult to get a diagnosis in all the patient, and because of the financial concern, we cannot do biopsy in all the patient. But this needs to be done because we need to increase the survival in lung cancer. Now, we know that a lot of targeted therapies have come. Lung cancer has just exploded. So many options that there are in lung cancer. And another thing I just want to make a passing reference is that screening tests are, which is showing that low dose CT is a good screening test, especially in smokers. But there are other fallacies in that only 15 years is taken, and second, many patients are more than 15 years, and then there is no screening test for a non-smoker. And of course, the screening tests are not followed in our country in letter and spirit. And then the diagnosis of bronchoscopy and now newer versions have come. So these are the issues which we deal in our day-to-day practice and which lead to a late diagnosis of this cancer.